I'm Kjell Arne Johansson. I'm a professor at Bergen Centre for Ethics and Priority Setting in Health, and I will give a mini lecture on DCEAs and ECEAs. Extended cost-effectiveness analysis has this underlying assumption. Standard cost-effectiveness analysis only look at the total, or the average effect, the cost per average effect. The challenge is that CAs are insensitive to distribution. However, when extended cost-effectiveness analysis was introduced from DCP3 and in 2016, it opened up for looking at distribution of outcomes for both health gains, out-of-pocket expenditures averted, and financial risk protection from services. Here you see an example of results from extended cost-effectiveness analysis where you see deaths averted for 2 diseases. And you have 5 income groups from the poorest to the richest. And typically an intervention will have higher effects in populations with high disease burden, and very often that would be in the poorest groups. So the poorest would benefit more than the rich in this study on rotavirus vaccines. This distribution would be ignored in standard cost-effectiveness analysis. In addition, the financial risk is included, but before you can look at financial risk, you need to have an estimate on, if you scale up, for example, as in this example, a rotavirus vaccine, you would see that you would avert some expenses because patients don't get sick. And typically the rich would benefit more from private expenditures averted because they utilize services more. However, if you look at the financial risk protection, you don't have the same curve as you have of private expenditures averted. And that is why we measure, for example, financial risk protection as poverty cases averted or catastrophic healthcare expenditures averted. Because then you need to divide the private expenditures averted with the total household consumption or income. And then typically the benefits would be higher among the poor, even though they utilize the services more. And then you can combine both health benefits and non-health benefits, financial risk protection in one curve, and you could have a willingness to pay threshold, outcomes per $1 million, for example. And here you see in India and Ethiopia how the rotavirus vaccine would play out for the poorest quintile up to the richest quintile for Ethiopia and for India. And you typically see that it's the poorest that have the highest health benefit, highest number of deaths averted per $1 million invested, and they would also have higher financial risk protection because they have a higher burden of disease. Now, recently a new method has been introduced that by large is similar to extended cost effectiveness, but not fully. And that's called distributional cost effectiveness analysis, DCEAs. Here you see the typical components of a DCEA. You simulate distribution, you do look at the baseline distribution, you apply a policy, and then you look at benefits and opportunity cost. And you can measure the health-related consequences. So far so good. This is more or less the same as we did in ECEAs. However, DCEAs does not look systematically into financial risk protection. However, the difference with DCEAs is that you have also equity methods on managing distributions. So you go from a dashboard to approach to where you can also give concrete recommendations from the policies you analyze. And here you see typical figures, the efficiency equity plane, building on the cost and effect plane, where you could place interventions in the upper right corner, win-win, both a good equity impact and good efficiency impact, or you have lose-lose, or win-lose, lose-win. So here is an overview of the questions you need to ask when you want to tailor the type of DCEA that you do. So first question you need to ask is, do you have a model where you can look at the distribution of consequences? Are you looking at a small population within a larger population? And if you cannot look at distributions, The answer is no. You then could apply direct equity weights, for example. But if you're able to say something on distributions, then you need to ask the question, what consequences? Do you look at current health, lifetime health, and financial risk protection? The second question you need to ask is, do you do a full or partial distribution? If you do a full, you can look at baseline benefits and opportunity cost, and if you do a partial, you can look at severity and other benefits. But if you have a full evaluation, you could apply social welfare functions. So here you see an example of a DCEA where you typically have this distribution in lifetime health, where you see this is a study from Ethiopia, where you see that the poorest quintile have lower both life expectancy and lower healthy life expectancy compared to the richer. It's almost 10-year difference between the richest and poorest quintiles. And then the question is, this paper analyzes two policies. It's a rotavirus vaccine, but you have a standard approach in the policy where you scale up vaccines for everyone. And then you typically know that it's the richest that will benefit the most. But the alternative policy is the pro-poor vaccine, the dark gray, and then that's where you give extra weight to those living in rural areas. You need to invest a little bit more or much more to reach the hard to reach, the poorest populations. And the DCEA typically measures the net health benefit. And then you have a willingness to pay threshold. Here in Ethiopia, for the rotavirus vaccine case, it was just applied $50 per capita. And then if the ICER, or the cost effectiveness rate, is above this threshold, it means you get a negative health benefit, and this is the formula for how you calculate it. And you could, in a DCEA like this one with the rotavirus example, you could produce a dashboard. I get very often dizzy when I look at dashboards like this, and it doesn't give me any good decisional support because it's just very descriptive. But DCEAs, they take it one step, this method takes it one step further, where you can look at the policies in a health impact plane. And you have the traditional cost effectiveness plane, where you see the opportunity cost of investing in the pro-poor vaccine program versus the standard program. And then you see the cost effectiveness of the intervention. The ICER would be here, going from the more cost-effective to the less cost-effective program. You see the ICER would be here, and with a willingness to pay of $50 per capita, it would be higher. However, it would be included if you increase the willingness to pay threshold. However, interestingly, if you apply Atkinson index, a social welfare function, and a preference to inequality, you would see that it has a positive equity impact, because it scores the pro-poor vaccine program does not cash out the full benefits of the standard vaccine program, but you have a more equal distribution, and this is captured in the Atkinson index. And then you could change the willingness to pay, and you would have also positive cost effectiveness result, as you saw in the left corner. Another way of illustrating the equity efficiency trade-off with this rotavirus example is you could have also, with the Atkinson index, you could have variations in health inequality aversion, and that is measured with the value epsilon. So you could have zero preference against reducing inequality. That means you're a hardcore utilitarian. Or you could have maximum value towards always favoring equality, and then you would have a epsilon of very high value. But people would probably be somewhere in this range. And you could look at the opportunity cost of the pro-poor versus non-pro-poor vaccine of rotavirus. And with a willingness to pay threshold of 50, you see that the health benefits becomes negative when you reach an epsilon of 6, which is a pretty high preference to inequality. And this is the sort of healthy adjusted life years equally distributive equivalent is measured by just multiplying the healthy adjusted life years with 1 minus the value of the Atkinson index. Thank you.